Okay, welcome back. Now, the model we've got on the slide here looks at that first line of that page, and you can see the GP in this case, we haven't looked at the sleep and the depression and the social things, but just the lower back pain part of that plan. There's a lot more words. So there's a lot more structure being applied here. And you'll notice that the goals have changed. They're much more specific now, so they're actually smarter goals. So they still prevent worsening of pain, but now the goal of being able to go out or shop within the next month. So there's a time frame for that one. Longer term, to be able to return to work. So there's a long-term goal we're aiming for. How long-term, we don't really know from this plan, but there's something longer term that Mary and the GP have sort of devised. We're still trying to rationalise pain medication, reduce side effects, but you can see the actions, there's a lot more structure here. So there's a number of things that are incorporated as part of this, and we'll allude to a lot of these issues in the next few slides when we talk about developing a pain management plan. But if you contrast this plan with the initial plan, there's a lot more structure, which is what we have to apply if we're developing or assessing a patient who's developed yellow flags. So when we're developing a pain management plan, it's important to develop, but in consultation with the patient, is the patient's plan that you're holding and you're helping design, but if they don't feel any ownership for it, they won't have any buy-in. They're not likely to take up on your advice as much as if they've contributed to it. One of the things I've often done with patients is ask them how things would improve. So if I'm looking at a functional goal and a functional task maybe, I even give them like a crystal ball or a sort of a time machine type of analogy, saying if we went forward in time 2 months, how would we know by looking at you, we couldn't ask you any questions, but how would we know if we looked at you, you'd actually be improving? And you'll get a variety of responses from that by the patients. One patient that I had an old stoic farmer who I could have suggested a number of ways that he could have functionally improved, but I asked this very open-ended question, how would I know by looking at you in a few months' time you actually improve? And his example to me surprised me, but it was his own example. He said, I'd be washing the dishes more. Now, my idea of a stereotypical stoic farmer was not that someone who wanted to wash their dishes. But he explained to me then that he had teenage children, and after a day working on the farm, coming home, the kids were running amok. And for him, the ability to wash dishes was his little meditation time. It gave him 10-15 minutes of time without the kids because they weren't going to help him. It gave him time to just sort of relax and get his mind back so that he can attend to his family duties after his dishwashing experience. And unfortunately, due to his lower back pain, he was unable to retain that posture to wash the dishes. He'd lost that functional activity that was quite important to him. And so one of our goals was trying to get him back to washing his dishes. I would never, in my wildest dreams, have thought of offering washing dishes to what I thought was a stereotypical farmer as an activity. But because I asked him in a way that was open and allowed him to open things up, he then owned that goal. And then we organised some tasks to try and achieve that goal. And because it was his goal, he was more focused on actually achieving that. So it's important to spend a little bit more time. It does take a little bit more time to consult with the patient about what their goals and actions may be that are appropriate for them. But believe me, that time is well spent. The patient's more likely to take some ownership over this, become more active in the treatment, and often suggest things that you would be surprised about, but actually are much more useful for that patient individually. The important part about a pain plan is also not just to emphasise the opioids. While they're going to be part of this, and remember this is an opioid prescribing module, so your pain plan initially may not have even included an opioid. Because this is an opioid prescribing module, we've put an opioid in this to allow us to at least track and follow that up. But if you're putting opioids in there, make sure they're not the only thing. We don't want to overemphasise the medication, because as we've heard earlier, the medication is only one tool, only a small portion of the tool of the whole approach, not the total plan. Include physical treatments and other medications, and ways and methods of addressing social and mental health comorbidities. The goals are really important, and making sure, again, we're emphasising the functional outcomes rather than things just such as pain control, much more important. So when we're talking about goals, I like to use the acronym SMART, the goals being specific, measurable, achievable, realistic, and time-based. If you can get those 5 features within a goal, it's going to be a very good goal because it's got those features, but also very much measurable later on and sort of reviewable. And so rather than just someone having, I feel better, or I don't feel better, so your goal may be very not a very good goal, to feel better, if you wrote something different saying, I would like to be washing the dishes next month for at least 5 minutes. Much more, it's specific, it's measurable, it's achievable, 5 minutes compared to 0, probably achievable, it's realistic, and it's also time-based within that time frame. So it gives us a really good opportunity to review those things. So set up your goals early so that you can review them much more realistically and appropriately. Next, in terms of developing a pain management plan, make sure you're structuring the actual opioid treatment appropriately. So how often that review should be occurring, what monitoring is going to be occurring at the time. For the higher risk patients, more controls can be using a pharmacist for weekly pickups or daily pickups, that sort of thing, rather than just picking up the whole month's worth at one time. Using structured programs. This is chronic, regular, predictable pain. We need chronic, regular, predictable pain management treatment. So structured rather than PRN regimes will provide more structure but less opportunity for patients to lose control of their medication if they're taking it as sanctioned. Please use longer acting or sustained release formulations rather than shorter acting opioids. We want to avoid that peak and trough nature of the pharmacokinetics, and also we want to minimise that reinforcing behaviour that the shorter acting opioids can do. So sustained release formulations or longer acting medications, opioids, will be a more appropriate choice. Work out an exit plan as well. So when we would reduce the treatment dose, or when we would cease it altogether, or refer further along. And so they can be basically usually when things aren't working. So if you set up some good, smart, functional outcomes, and after a period of time, the barriers to those outcomes were addressed and those outcomes aren't being met, well, the treatment's not working. So if the treatment's not working, we need to stop it. There's no point continuing with treatment that's futile. And so you may have to look at other forms of treatment. And that can include an opioid. So if the opioid's not working to achieve those functional goals, part of the plan should ideally include an exit plan. When would we stop? When would this trial review and see whether it's worth continuing or worth ceasing at that stage? It's also highly recommended to use a formal agreement when commencing S8 medications, which include opioids, and those who are already on S8 medications to, if they're running into some aberrant drug use, like Mary with her yellow flags, then setting up a formal agreement with her. Avoid the use contract. The term contract is applicable, but it's really not a legally enforceable document. And ideally, it should be an agreement between you and the patient, what your responsibilities and roles are, and also the patient's responsibilities and roles. So you can put those sort of things within the contract itself. And again, referring back to the universal precautions checklist we referred to earlier, will give you a few ideas of what to put in that agreement. When we're structuring chronic opioid treatment, focusing on safer prescribing, there's a few important things to ensure that we're continuing to include in our treatment plan. Make sure the patient understands that there should be one doctor and one pharmacy, where appropriate, involved. This helps reduce the risk of doctor shopping or prescription shopping, but also allows the health professionals to be consistent. So you or the pharmacist or both can regularly see the patient and observe changes over time. If it's a different pharmacist every time, then it's a different first-time experience every time. If it's the same pharmacist every single time, then they may actually phone you and say, look, Mary's come in this time, she's a bit more drowsy than she normally is. And that can be really important information to get. So try and keep the treatment team quite consistent. You need to make sure you've got permit involved if it's a permit medication, so all opioids in Victoria, beyond the 8-week period. Or if they're already dependent, then from the word dot, but otherwise from 8 weeks, you would certainly need a permit applied for. One other thing you can do for high-risk patients is download from the Medicare site the authority to release personal Medicare and pharmaceutical benefits scheme claims information to a third-party form. And this is a voluntary form. It's a form that patients can fill out for you, and that basically give you permission to get a copy of all their medication, PBS medication dispensing, and/or all their Medicare item number, their MBS consultations and procedure information as well. This can be used as a tool, but it's a voluntary tool, but it can be used as a tool to verify a patient's history for those higher risk patients. We talked earlier about interval dispensing, and that basically is where we're limiting the duration of the dispensed medications. So rather than giving them a full month, we basically give them a shorter period of time to have the medications. So you still prescribe a month's worth, for example, but maybe they pick up a week's worth at a time. So they go to the pharmacy once a week or once a day if they're a higher risk patient. Another important thing I think it's really important not to forget is just to provide the patient with a severe pain plan. What to do if things are bad on that day, really bad. I find whenever I do this, I find the need to actually instigate a severe pain plan is minimised. I suppose having the reassurance that the doctor has at least thought about a bad day and we've got a backup plan can reduce some of the anxiety about what if tomorrow's a bad day. And if that anxiety is reduced, then the need or the amount of pain is often reduced as well, so the need for the severe pain plan is not necessary. But there are going to be days where there's severe pain. And so you need to work out with your patient what that pain plan could be. Whether you suggest to the patient they come in regardless and you'll fit them in no matter how busy you are. Whether there's a backup sort of treatment plan. Whether they need to do some more physio or a hot bath or get some massage. One thing to avoid with the severe pain plan is the PRN medication. Here's some extra medication just in case you have a bad day. Certainly avoid that part of things. But have some sort of backup plan, even if they give you a call and you give them some advice over the phone. But something they can go so they can be reassured that there is a backup plan and not just fixed on the same plan all the time. With your patient agreements, again, consider this agreement for all patients, but particularly the higher risk patients, and include all these topics that are on the slide. So avoiding medications from other sources, avoiding unauthorised dose escalations, what happens if they're running short? Well, they shouldn't be running short if they're taking it as authorised, but basically the fact that you're not going to be refilling their scripts early. Talking about use of other drugs, illicit and illicit drugs. So whether they're sourcing other opioids elsewhere, whether they're taking another sedative like, for example, cannabis or heroin, whether they're taking another sedative like alcohol or a benzo, asking about those medications. The use of urine drug screens, and we'll talk about that very shortly. Diversion of medication to others to avoid doing that, absolutely. The attendance of appointments, how critical that will be in terms of making those appointments, and if they need to be cancelled, to reschedule and to make sure that they're adhering to your treatment plan or your agreed treatment plan. Who's communicating amongst health providers, so making sure that they're aware that you'll be phoning the pharmacy occasionally to find out how they're going. And also, we talked about earlier, the chronic opioid treatment cessation plan, when things will be stopped or referred onwards to a more specialist program if things are becoming more difficult. So all these things are important. We would strongly encourage you to have a version of a patient agreement plan. There are a number available for you. We'll provide one in the resource pack, but if you just use Google to look on the web, there's going to be a number of opioid agreement plans and you can modify your own accordingly. Again, if you're going to do so, use that universal precautions checklist as a nice little checklist. We mentioned earlier about urine drug screening, and it's worth just pointing out what this actually is. It's important if you're going to utilise this form of toxicology to explain the rationale to the patient. Again, it's about their safety rather than about being punishing. So we're really looking at, it's a safeguard to ensure that they're taking it. And from your point of view, it's more collaborating the history with what you're seeing in the urine drug screen. It's often part of the initial assessment that you may want to do, and you can utilise it as sort of an ongoing monitoring. But we wouldn't suggest doing it on a regular monthly basis, for example. But the occasional surprise one or the occasional random one can provide some information. By asking the patient, saying, look, this week we're going to be doing a drug screen, so I'd like you to provide a urine sample just to check that medication's okay in your system and there aren't other things in the system that would cause a problem. Often you'll get a history back to the patient, oh, actually, doctor, I forgot to mention that I've also taken X medication. Sometimes you get extra information just from the fact that you're suggesting the urine drug screen. Now, the urine drug screen is a qualitative test. It's not a quantitative test generally. So the basic PBS one gives you a number of classes and it tells you whether it's detected or not detected. It doesn't tell you how much or when it was taken, but whether it was detected or not. There are some false positives, so don't take it absolutely, but it's a good clue about what's actually going on. A big clue is if someone's been prescribed say, sustained release morphine, for example, and you did a urine drug screen and it was not detected, as in the opiate class not detected, then some questions need to be asked about where this morphine has gone. And often the case may be that it could be sold or diverted elsewhere. But you need to make sure, you may want to repeat the test if you're not sure about the results themselves. Some pathology providers will provide a more quantitative test, but this is usually at a large cost to the patient. So it's worth asking your pathology provider before you order the quantitative test to ensure the patient is out of pocket a large sum of money. So we looked earlier with Mary, who was a patient exhibiting yellow flags. What if they're red flags? What do we do then? Well, if we see a patient with red flags, it's really, again, we need to express those concerns with the patient. It's important to do that so they understand why you're going to change management. Yellow flags, we said, don't change management, just structure it a bit more tightly. But if it develops into a red flag situation, we have to change. Red means stop and change altogether. So, firstly, it should trigger a discussion with the regulatory authorities. In Victoria, that's the Drugs and Poisons Regulations Group. You should at least phone them to find out if the patient has a history with them. They can give you more information. Discuss or refer this to someone who's more experienced in this area. So you can retain control with the patient's management, but at least get some advice. And again, towards the end of this module, we'll give you some resources about who you can phone if you don't have ready access to an experienced colleague nearby. Now, one option for you, if you're confident and you can think your patient will do this, is to structure or provide a trial of very, very structured treatment. Daily pickups at the pharmacy, for example. Weekly reviews with you. Very, very structured and, basically providing as much structure and limited options to lose control of the medication. That's one option. But it can be quite problematic to do that, and if you're treating dependence without any pain, it's actually illegal. You need to prescribe opioids for pain. So if the patient doesn't have any pain anymore, but they're dependent, then you can't use the opioid in this case anymore. The other options for us for patients with red flags is to change treatment and switch them over to an opioid substitution therapy treatment. All doctors in Victoria now can prescribe up to 5 patients without any training the opioid substitution therapy medication buprenorphine with naloxone, and that's an option for all patients who are running into real big problems. After this module, you're invited to continue with the next module, which is basically prescribing methadone and buprenorphine for opioid-dependent patients. So you'll have done the training by the time you complete this whole workshop series. And that way you can prescribe for potentially up to 5, but also more than 5 if you wish to. So the next module will actually provide you with the training information to do that. Often a more appropriate management for patients with red flags or those exhibiting dependence is to transfer them to an opioid substitution therapy treatment. And that can include buprenorphine for doctors that haven't gone through the training that you'll go through, for up to 5 patients. But for yourself, after this module, you'll be attending that one-day workshop, and at that workshop you'll be trained to prescribe methadone and buprenorphine for patients with opioid dependence. Now, we've mentioned S8 medications, or otherwise known as Schedule 8 poisons. These are controlled drugs, previously called drugs of addiction, and they're much more strictly controlled than the usual things we prescribe, such as S4 medications. And they include all opioids, including morphine, fentanyl, oxycodone, codeine phosphate, methadone, and buprenorphine. And they also include 2 benzodiazepines, flunitrazepam and alprazolam, as well as the barbiturates and the medications for ADHD. One little thing to note is codeine phosphate by itself is a Schedule 8 medication, but codeine phosphate in combination with something else, like in Penadine Fort or in Nurofen Plus, is not. It's only its pure form, so codeine phosphate tablets or Linctus are an S8 medication. For all S8 medications, no matter who's paying for it, so whether it's Medicare, work cover, TAC, or privately, in Victoria you need to obtain a permit in the situations if someone's deemed to be drug dependent. So look at the DSM-4 criteria referred to earlier. If they are drug dependent, before you prescribe your first script, you have to have applied for a permit. For everyone else, you've got an 8-week trial period. So a period where you can trial a medication, and if it needs to be continued beyond 8 weeks, then that can you need to apply for a permit at that stage. The other exceptions are where you would when you're prescribing 3 specific drugs, and they're the 2 drugs, dexamphetamine and mycophenolate for ADHD. As a GP, you won't be doing that very often, but also methadone in terms of the 5-septone tablets. They're the ones you need to prescribe, get a permit earlier on. Now, importantly, that 8-week duration for the majority of patients includes 8 weeks of total treatment, not necessary treatment by yourself or in your care. So for example, if someone had 8 weeks or 7 weeks of treatment in a hospital and came to see you and had basically 1 week left of their treatment, if you're going to prescribe more than that 1 week, you would need to apply for a permit even from today. So it's 8 weeks of total treatment, not just treatment in your care. And there are some exceptions about these permits. So if you're working in a multiple practitioner clinic, you may prescribe without a permit if the following apply. If the treatment is provided at that clinic, if another practitioner at the clinic already holds a permit to treat the same patient with the same drug, if the treatment is in accordance with that permit, and if you have access to the history and adhere to the current treatment plan, i.e. you're not making any changes to the treatment plan, then you can prescribe without a permit, because the permit is already with another doctor of the same clinic, which you've got the notes to. There are some other exceptions where you don't have to apply for a permit yourself, and they occur where a patient is a prisoner treated in a prison, is a resident of an aged care service, or is an inpatient, not an outpatient, but an inpatient treated in a hospital. In those situations, a permit isn't required. But as soon as an inpatient becomes an outpatient, for example, the permit period would be applicable. And there's also an exception where you don't have to apply for a permit if a patient is suffering from pain related to cancer. Now, the form you'll be filling out is pretty much the same form. The permit form is also got a cancer notification form. So there is a form you have to fill out, but it's not strictly a permit and you won't get a permit back for that. So to summarise, the 8-week period is basically intended to allow you to initiate short-term relief if appropriate, and most short-term acute settings will have settled well within the 8-week period. If it's beyond 8 weeks, the permit system is put in place to try and avoid multiple practitioners treating the patient, fraudulent claims by drug-seeking patients, and also where a patient claims to be transferring from another clinic and needing prescriptions or for continuity of their ongoing treatment, application should be submitted immediately, even if there's no intention to prescribe further prescriptions, because the history of something suggests that it's probably been longer than 8 weeks. Just a little side note, if someone's asking you for, say, for example, 80 milligrams of OxyContin BD as a prescription, almost always, I've never heard of a case where someone is still within the 8-week period. To escalate to that high dose, it takes much longer than 8 weeks. And so for those sort of patients with high dose requests, even as a one-off, permit should be looked at initially because the period is more than likely to be 8 weeks, even if the history from the patient suggests otherwise. One thing to note though is that if there's an emergency situation, then you can address that emergency. So a patient is highly deemed to be opioid dependent, but comes in with a broken leg or a heart attack, please treat the emergency and then apply for a permit after that. You still need to apply for a permit, but address the emergency. The other thing is that the application of the permit is good enough. Sometimes there's quite a delay of weeks to months sometimes to get the permit back to you. It can be quite a big paperwork pile at the Department of Health. So in applying for the permit, then you're allowed to prescribe until the permit either expires, you cease it altogether, or you're given a rejection, and you'll be told of that quite directly. In Victoria, we've got another category of medications called S11 medications, or drugs of dependence. And they include the S8 medications we've already referred to, plus some Schedule 4 medications. So they include things like dextropropoxyphene, benzodiazepines, duramine, anabolic steroids, and pseudoephedrine. Now for these medications, so all the S8s plus these other ones, you need to take a couple of other steps. You're required to take all reasonable steps to confirm a patient's identity, so some photo ID would be fine, and also to handwrite the components of any computer-generated prescriptions to foil forgeries and to enable pharmacists to comply with the regulations of dispensing the medication. So they're the only extra things you would need to do for all S8 and some of these S4 medications. So someone who's opioid dependent, there are two main treatment pathways. One is a withdrawal, or sort of a short-term detox, and that is basically reducing and ceasing the opioids in a short term, and there are a number of ways of doing that. One is basically reducing the actual opioid being prescribed, and the other one is to use a high-dose buprenorphine regime, which you'll learn at the face-to-face workshop on how to do that. These both need a pain plan, because you may be coming into some problems with the actual withdrawal syndrome itself. So we need a regular review and a plan for that. If you're not sure how to do that, either wait till the face-to-face workshop or speak to an experienced colleague. The other option for treatment of opioid dependence is opioid substitution therapy. And this basically stabilises the patient on a long-acting opioid, such as buprenorphine or methadone, which have lower abuse potential, and allow patients to stabilise other parts of their life while their opioid use is quite stable. It's highly structured, there's lots of review, and patients can then develop psychological, social, physical problems and starting to address those. Do not prescribe other opioids for the maintenance of dependence. Just a last word on opioid substitution therapy. Both methadone and buprenorphine are effective analgesics. They're opioids in their own right. They're long-acting opioids, and so they are effective, and they'll probably work for chronic pain as well as other opioids work for chronic pain, up to about 20 to 30% subjectively. They provide more structure, and there is greater adherence to the dosing regimes. It's once a day dosing, it's often supervised with the pharmacist, and drug monitoring is often more easier to apply as well and monitor.